later if you want to. And the slides will be sent out at the end of the session as well. Okay. So first of all, just to kind of cover the basics, what is a cardiac arrest? So cardiac arrest is essentially a sudden cessation in cardiac output, and that's characterized by a loss of consciousness, and then either one of apnea, so no breathing, or agonal gasping, which is kind of an irregular, shallow gasping breaths, or non-palpable pulse as well. In this session, we won't be covering the whole ACLS algorithm in detail of doing CPR, rhythm checks, defibrillation, giving you resus medications like adrenaline and amiodarone. But while you're doing that process, you should simultaneously be evaluating and treating the reversible causes of cardiac arrest, your H's and T's, which is what we're going to go through today to help you get return of circulation in your patients. Okay, so there are 4 H's and 4 T's, and they're the reversible causes of cardiac arrest, and we'll go through each one in turn. It's important to remember, though, that these also apply to peri-arrest scenarios, so where the patient is unstable and at risk of cardiac arrest, but they haven't actually gone into cardiac arrest yet. So where there's evidence of low cardiac output, so if they're very pale and sweaty, cold and clammy, if they've got impaired consciousness or syncope, if they're very hypotensive as well. So correcting the reversible causes before it progresses to a cardiac arrest can help you to prevent that from happening. So it's important to consider them at that point as well. Okay, so we're going to start off and we're going to go through each one kind of with a case background, I suppose. So this one, case 1, so you've got a 34-year-old female has been admitted into ED via the ambulance with an acute severe asthma exacerbation. So far, all the treatment she's been given has not worked. She's become bradycardic, the wheezing is quietened and then stops, and the O2 sats trace just reads as undetectable. So the patient has gone into cardiac arrest. In this case, why has that happened? So if you want to, I think I can give you a box to enter your response in. Why do you think in this case, what's the cause of this patient's cardiac arrest? Yeah, okay, fab. Great. So yeah, in this case, this patient has hypoxia. So there's an inadequate supply of oxygen to the body tissues. Also someone that put tension pneumothorax. Also potentially in someone with asthma, so you're not wrong there. So someone with asthma, especially if they're receiving high flow nebulizers or are put on a ventilator, they're at risk of tension pneumothorax. So you are also correct there that that's something you'd want to think about. Yeah, but here we're going to talk about hypoxia. So there's an inadequate supply of oxygen to the body. So this can be due to various things. So there could be a problem with ventilating the lungs. So there's like an airway obstruction or airway trauma. So foreign bodies, aspiration, anaphylaxis will come under that. A problem with picking up the oxygen in the lungs. So severe pneumonia, asthma, COPD can all cause that. Then there could be problems with transporting the oxygen bound to hemoglobin in the blood. So severe anemia, there's not enough blood cells to circulate. Carbon monoxide poisoning as well. Then you can get issues with offloading the oxygen to the tissues, so where there's poor perfusion. Neurological issues, so respiratory depression, if there's a neurological problem affecting respiratory drive. Or if there's exposure to a low oxygen environment. So, for example, high altitudes where there's low oxygen. Okay. So with hypoxia, you want to look out for low oxygen saturations primarily, cyanosis of the skin and the mucous membranes, tachypnea, so prior to arrest, they'll be breathing very quickly, and altered mental status prior to arrest as well. If they've got any history of a respiratory problem or exposure to carbon monoxide, for example, and on their ABG, you might see a low partial pressure oxygen and high lactate from the anaerobic respiration that's going on in their body due to the hypoxia. You might also see signs of respiratory distress, so things like stridor, if they can't complete full sentences, if they've got a low peak flow, high respiratory rate, or a low respiratory rate if they're starting to become exhausted. So those can all be signs of respiratory distress that are potentially going to lead to a cardiac arrest. And in terms of treatment, so obviously we all know our CPR, you call 222, get a defibrillator, give them the ACLS drugs. But aside from that, for where you're suspecting a hypoxic cause of the cardiac arrest, you want to provide some supplemental oxygen. So 15 litres via a non-rebreathe if they are breathing for themselves, or in this case, a bag valve mask or over a ventilator. To assist this, so if you're using a bag valve mask, you do the head tilt chin lift at the same time. You might insert an oropharyngeal or nasopharyngeal airway to help as well. Or you can get an I-gel airway in place, supraglottic airway, or eventually an ET tube, which is your kind of definitive airway protection. And then you'd want to treat the underlying cause. So intubation, mechanical ventilation, if you need it. For pneumonia, for example, you might do a sepsis screen, give IV antibiotics. For carbon monoxide poisoning, you'd secure their airway and then give them 100% high flow oxygen to try and dissociate that carbon monoxide. So that's hypoxia, which is one of our reversible causes. So the next one, which I'll put up here. So a middle-aged man, middle-aged homeless man was found unconscious on the grass in a local park by a member of the public. When the ambulance arrived, he was bradycardic, GCS of 3 and appeared cyanotic. The paramedics got him on the back of the ambulance, but he goes into cardiac arrest and it shows as asystole on the monitor. So in this case, why do we think that might have happened? Lovely, yeah. Fab. So hypothermia is the most likely one here. So I'll move on to causes of hypothermia. Quite simple, really, being very cold. So being in cold water, exposed to cold weather. So primarily hypothermia generally is caused by cold exposure. We class someone who's hypothermic as when their body temperature is below 35 degrees. But you can get secondary hypothermia as well, but it's not as common. So where there's a condition that's affecting the regulation of temperature. So if they've got burns, if they're in surgery, if they've got sepsis, if they've got hypothyroidism, sometimes with strokes or substance misuse as well, can all cause secondary hypothermia. And particularly so in children and the elderly, people who misuse drugs and alcohol, those with dementia and the homeless, or people with poor quality housing where they don't have adequate heating, they're all particularly at risk for hypothermia. Okay. So in recognizing hypothermia, low core temperature, obviously, cyanosis, bradycardia, but they will initially be tachycardic when they're trying to compensate for the cold. Bradypnea, and again, initially they try and compensate. Altered mental status, shivering, and again, so shivering is trying to compensate, generate heat. due to the hypothermia, but as it gets worse, that stops because the muscles are essentially starting to shut down. You could get rigidity. It's referred to as pseudo rigor mortis. So complete kind of skeletal muscle rigidity. And if they've got a history of cold exposure, then it's something you want to think about. In terms of treating hypothermia, so you've probably heard the phrase, you're not dead until you're warm and dead. So resuscitation for patients that are in cardiac arrest and are hypothermic is usually very long. So hypothermia, patients that are hypothermic will usually be resuscitated for quite a long time while we're rewarming them. So hypothermia can cause VF, but defibrillation and inotropes and that sort of thing aren't usually effective until the patient is around 30 degrees. So they need to be rewarmed first. So you'd want to remove any wet clothing, monitor their core temperature. So that means something like an esophageal temperature probe or a rectal or bladder temperature probe. You can do external rewarming, so with things like warm blankets or the bear hugger that you might have seen in surgery and things like that. Internal rewarming, so with warmed IV fluids. You can do thoracic and peritoneal cavity lavage with warmed fluids and warm air ventilation as well. And then if all that doesn't work, you can progress and you can do direct warming of the blood. So taking the blood out, warming it and putting it back in again through hemodialysis or ECMO. And that's kind of the last line in terms of treating hypothermia. And we use this staging system called the Swiss staging system, which just categorizes the different levels of hypothermia. So you can have a look at that here. Goes from mild through to severe, and then someone who's in cardiac arrest or where it's now irreversible. So initially they'll be conscious and shivering, trying to compensate for the drop in temperature. And as it rises, they'll lose consciousness. So as their temperature falls, they'll lose consciousness, they'll lose their vital signs. And so someone who's a kind of hypothermia 1 level, you can put them in a warm environment, give them warm clothes, warm drink, and they'll probably be fine. Hypothermia 2, you want to put them on cardiac monitoring, give them kind of active external and maybe some minimally invasive internal rewarming like warm fluids. And then once you kind of go above that, that's when you want to think about airway control and giving them invasive core rewarming, potentially ECMO, and that sort of thing. So that's hypothermia. So next one. So we've got a 66-year-old male who's presented with a sudden onset sharp central back pain, stabbing in nature, very severe, associated with nausea, sweating and feeling faint as well. He's got hypertension, he's an ex-smoker, very pale and clammy, tender over the epigastrium, and his blood pressure is very low and he goes into cardiac arrest. Why do we think that's happened in this case? Any ideas? Yeah, great, yeah. So in this case, it's most likely hypovolemia, being pale and clammy, the low blood pressure, kind of point us towards potential volume loss. So he's in shock. And the history here would be consistent potentially with a ruptured AAA. So that's the first thing we'd want to consider. So with hypovolemia, there's a loss of blood volume, and that leads to a decrease in cardiac output. So hypovolemia can result from various problems. So you can get bleeding from vascular ruptures, so a AAA or GI bleed, severe dehydration, diarrhea and vomiting, they can all cause it as well. Burns in particular, you can actually lose a lot of fluid through burns. Traumatic injuries like amputation or internal bleeding, so you can actually bleed your whole blood volume into your pelvic cavity. So it's really important to think about internal bleeding in someone that's hypovolemic. Metabolic causes like DKA cause severe dehydration, and then through surgery as well. And in particular, you want to think about people that are on blood thinning medications or those that have bleeding disorders, because they're particularly at risk for this as well. So someone with hypovolemia, you're looking for signs of dehydration. So things like dry mucous membranes or decreased skin turgor, sluggish capillary refill, low blood pressure, obviously, tachycardia when they're trying to compensate for the low blood pressure prior to going into cardiac arrest, decreased urine output, if they are actively bleeding and you can see it, obviously, any history of blood loss, vomiting, diarrhea, or being on anticoagulants. And then for treatment, so for all these causes, we want to think about fluid resuscitation, so giving them IV fluids, crystalloid, to restore their circulating volume. If that's not working, so if it's refractory hypovolemia after you've given the maximum of 2 litres of fluids, then that's when you want to start thinking about giving blood products instead, or you'll end up giving them dilutional coagulopathy, because you're essentially diluting out all their clotting factors and that sort of thing. For hemorrhage, you want to give blood products, so packed red cells from the start instead of fluids, and then consider other blood products like platelets, fresh frozen plasma, cryoprecipitate alongside that to help stop the bleeding and replace those other blood components. You can give antifibrinolytic agents like tranexamic acid to help stabilize their own blood clotting, and vasopressors and inotropes can be really useful to help increase the blood pressure by inducing vasoconstriction and increasing the force of contraction of the heart. But ultimately, you do need to treat the cause. So for this patient I mentioned with the potential ruptured AAA, that would be they need to go to vascular surgery urgently. And with hypovolemia, you may already know about this. You have the massive hemorrhage protocol in hospitals. So the definition of what constitutes massive hemorrhage is a bit vague. There's various different definitions which I put on here as bullet points. But so if you've lost more than 1 blood volume in 24 hours, if you've lost 50% of your total volume in less than 3 hours, any bleeding in excess of 150 mils per minute, or any bleeding which results in a systolic BP less than 90 or a heart rate above 110. Those are all thought to be kind of definitions of massive hemorrhage. You can get emergency O-negative blood to give to patients while you're waiting to activate this process. So in the LRI, you get it in the transfusion lab, I believe, and then the maternity unit in theatres and in ED resus. They've got units in all those locations. So that's hypovolemia. So our next case here is an 84-year-old female on the cardiac ward, was placed on a furosemide infusion about an hour ago for pulmonary edema. She has a past medical history of AKI. The FY1 comes to see you because they're a bit concerned about their ECG, and while you're having the conversation, she goes into VF, cardiac arrest. So why do we think this has happened? And while you're doing that, I'm going to work out why the lights have just gone off in this room. Lovely, yeah. Great. So hyperkalemia in this case, caused by the furosemide infusion. So if I can go to the next slide. Yeah, there we go. So hypokalemia or hyperkalemia are both causes of cardiac arrest. So in hypokalemia, if you've got potassium less than 3.5, or in hyperkalemia where you've got potassium greater than 5, symptoms usually don't arise kind of at the borderline. So you'd usually in hypokalemia get symptoms below about 3, or if the change is very rapid. And then with hyperkalemia, it's usually above 7 is when you start to see the change. Or again, if it's a very rapid change, you might see it earlier. So potassium, as you probably know, is a very important electrolyte for maintaining the kind of resting membrane potential of excitable cells, which includes cardiac muscle. So abnormal levels of potassium can cause either reduced or increased muscle excitability by changing the baseline of the resting membrane potential. And that results in cardiac arrhythmias and in severe cases, cardiac arrest. So untreated potassium derangement most commonly causes VF arrest, which is a shockable rhythm. So there's various potential causes. So hypokalemia due to diuretics, alkalosis, diarrhea and vomiting, if they've got AKI or CKD, if they're on an insulin infusion, so insulin puts potassium into the cells, or if they've got dietary deficiency. And then hyperkalemia, so if they're on potassium-sparing diuretics like spironolactone, if they've got acidosis, so the hydrogen ions are being swapped for the intracellular potassium. Various drugs, so ACE inhibitors, angiotensin receptor blockers, digoxin, all increase the extracellular potassium. Diabetes, if their blood sugar is not well controlled. Rhabdomyolysis, so if someone's had a long lie, for example, they could be at risk, or high intake of potassium as well. And so I mentioned already that it can cause, depending on whether it's hypo or hyperkalemia, it could cause reduced or increased excitability. Hyperkalemia raises the resting membrane potential closer to the action potential threshold, so you're going to get tissue excitability. But that persistent voltage-gated sodium channel activation will lead actually to them being inactivated and get a reduction in total excitability. So hence in both cases, hyper and hypokalemia, the signs that we're going to go through on the next slide are all that of reduced excitability. So you'll see ECG changes, which we'll talk about in a second. Muscle weakness and paralysis, decreased reflexes, nausea and vomiting, confusion, abnormal glucose levels as well, potentially, especially in diabetics. And if they've got a history of kidney disease, using certain medications or having a nutritional deficiency. In terms of the ECGs, so we've got hyperkalemia and hypokalemia ECGs here. So the top one is hyperkalemia, so they're bradycardic, it's about 50 per minute here. And there you'll be able to see, hopefully you can see my pointer, but there's tall peaked T waves. and those are suggestive of hyperkalemia. ECGs in hyperkalemia can also show broad flattened P waves, which in some of these you might be able to make out as well, although it's a bit small. Widened QRS complexes, conduction blocks as well, so things like bundle branch blocks are quite common. And as the hyperkalemia gets worse, the QRS complexes and the T waves can combine together and fuse, and they create a kind of sine wave pattern going up and down, which is referred to as a pre-terminal rhythm. So that's suggestive of impending VF. So it's important to recognize that quickly. And then in hypokalemia, so here heart rate is about 68. The PR interval is lengthened. Narrow QRS complexes. There's some ST depression. So here in lead 2, a little bit in lead 3, AVF as well, and then V4 to 6 there, and V3 as well. You get T wave inversion, so you can see them dipping down there, and prominent U waves. So U waves are these ones going up after the T wave. And they're all suggestive of hypokalemia. And a good way to remember it is by this push and pull analogy. So in hypokalemia, you're pushing down, so you get T wave inversion, prominent U wave, and ST depression. And in hyperkalemia, you're pulling the T wave upwards, so you get peak T wave. The P waves flatten out, and the QRS gets wider. Question popped up. Where exactly is the U wave? Yeah. So the U wave is this part here. So after the inverted T wave, and then it goes up above the baseline again. And that's referred to as a U wave, which you see in hypokalemia. Okay. And in treating these, so you need to treat the underlying cause primarily. So if they've got vomiting, diarrhea, you need to treat that, or if they're on medications like diuretics, you need to think about how you're going to manage that. But with hypokalemia in the emergency setting, so you'd want to give potassium repletion, so IV fluids containing pre-added potassium chloride. You shouldn't exceed 10 to 20 millimole per hour when it's via a peripheral vein, just because potassium is very highly irritant to veins. But you can give higher doses. I believe it's up to 40 millimole per hour, and those can go through central venous catheters if they've got central lining. And they should be on continuous cardiac monitoring throughout potassium replacement therapy. And then with hyperkalemia, so you want to stabilize the cardiac membrane first. So that's done with IV calcium gluconate. And that ensures that the heart isn't going to be kind of further affected, essentially. You put them on continuous cardiac monitoring, you should see the ECG begin to improve within 5 minutes of giving the calcium gluconate. It helps to stop the effect of the high potassium on the cardiac membrane. And then once you've stabilized the cardiac membrane, you want to shift the potassium intracellularly to get it out of the bloodstream. So you give short-acting insulin like Act Rapid with dextrose. So the regime in Leicester is 10 units of Act Rapid in 50 mils of 50% dextrose over 15 minutes. And that shifts the potassium intracellularly to lower the serum potassium. And it's given with the glucose or dextrose to prevent hypoglycemia from giving the insulin. You can also consider giving inhaled SABAs like salbutamol as an adjunct, because they also help drive potassium into cells, but that's an unlicensed use, so it's not used very commonly. Or you can do hemodialysis as a definitive treatment to filter out the potassium in the blood So that's all the H's of cardiac arrest. So we're about halfway. Okay, so next case, we've got a 21-year-old male who's been brought in by ambulance after being stabbed in the right side of his chest, and the knife is no longer in situ. In transit, he's become progressively hypertensive, tachycardic, and short of breath, and shortly after arrival in ED, he goes into cardiac arrest. Why has this happened? Or someone's in immediately. Lovely. Yeah. Perfect. So this is likely a tension pneumothorax. So a tension pneumothorax is a life-threatening type of pneumothorax involving a one-way valve mechanism, which is what's being depicted here. So air is progressively accumulating in the pleural space, building up pressure, leads to hemodynamic compromise. So the one-way valve can originate in the visceral pleura, which is what's being shown here, or it can be in the parietal pleura through an external injury. Air enters the pleural space on inspiration when the intrathoracic pressure decreases, but it can't exit again because of this one-way valve mechanism. It can't get back out. So the air progressively accumulates in the pleural space and you get increasing pressure within the chest cavity. That lung on that side will collapse under the compression. You'll get compression of the opposite lung, of the trachea, of the heart, and the superior vena cava. The inferior vena cava becomes kind of angulated. And then overall, obviously, their respiratory function is going to decrease. The compression on the venous return of the heart is also a problem. And then as a result, cardiac output falls. So if they're not already in cardiac arrest, anyone with a suspected tension pneumothorax is automatically considered peri-arrest. It's very serious. And again, there's various causes of it. So you can get infective causes. So any kind of pulmonary infections, pneumonia, and pulmonary TB. We get inflammation of the alveoli and they can rupture. Traumatic causes, either blunt or penetrating trauma. So you can either get like blunt trauma causing a rupture of blebs or bullae that are already there, or a penetrating chest wound, which creates the external valve mechanism. You can get things like these subpleural blebs or COPD bullae, so bullae are like air-filled cavities that replace the normal alveolar structure in emphysema as part of COPD. And the blebs are similar, they're small air pockets between the lung wall and the visceral pleura, so that's why they're referred to as subpleural. They're actually common in normal individuals, especially people very thin stature, or smokers as well. And those can rupture if they're put under force. They can be caused iatrogenically, so mechanical ventilation, especially when there's very high pressures of the mechanical ventilation. So we mentioned earlier about asthma. So if they've got high flow oxygen coming through with nebulized salbutamol, ipratropium and things as well, then they're a high risk of developing a tension pneumothorax iatrogenically, something that we've caused. But also things like bronchoscopy, biopsies, and putting in a central venous catheter, if it's going in here in the neck, can potentially cause a lesion to the pleura. Lung malignancies, so if the tumor is invading, you can get lung wall rupture. And congenital conditions, so things like cystic fibrosis, where you can get bronchiectasis and emphysema, and Marfan's and other connective tissue disorders that predispose you to kind of having these blebs and having them rupture as well. So in a tension pneumothorax, we want to look for low blood pressure, tachycardia, low oxygen saturations? Are they short of breath? Do they have chest pain? On examination, you might see there's chest expansion isn't equal. They might have hyperresonance to percussion, reduced or absent breath sounds, which is the most common feature, or tracheal deviation away from the affected side. It's important to remember that tension pneumothorax is a clinical diagnosis based on history and examination alone. So investigation shouldn't delay treatment. Generally, if you get to the point where you've got a chest x-ray and you're diagnosing tension pneumothorax from a chest x-ray, that shouldn't really be happening, because it should be picked up and treated as an emergency before that point. So you give high flow oxygen and then you need to decompress the pneumothorax to release that pressure. And to do that, you do that with a needle decompression. So you get some specialist kits that have got needles that are specifically designed for this, or you can use a wide bore cannula. So needle decompression, you put a large bore cannula into the pleural space through the second intercostal space, mid-clavicular line, or it can be in the fourth or fifth intercostal space, mid-axillary line as well. So you can do that as well with CPR ongoing, and you just want to listen essentially for a hiss of air coming out as you put it in. In a very noisy environment, like an A&E department, for example, you can attach a syringe with some saline in, put that in, and then watch for bubbles appearing in the saline as you withdraw back on the syringe. That's also another way to confirm that you've got it in the right place. It's important to bear in mind you can't use these closed system cannulas that you might see in some places because they have a one-way valve to ensure that nothing leaks when it's inserted. But that means the air, if you stick that in to decompress a tension pneumothorax, nothing is going to escape. So you need the kind of basic Ventron ones. These ones are pink, they're not big enough for doing this, but you'd need something bigger like a grey or an orange cannula for this. And then longer term, you'd need to insert a chest drain as the permanent solution. So that's tension pneumothorax. Next up, let's see if we can create another word cloud. Okay. So you've got a 68-year-old female who's recovering on the cardiac ward post MI. She develops hypotension and tachycardia. She's got distended neck veins and her heart sounds are quite faint when you auscultate. She goes into PEA on the ward. Why has this happened, do you think? Yeah, great. So likely here is cardiac tamponade, or yeah, so potentially. So there's always other things to think about, but here in terms of our H's and T's, this one, we're thinking potentially cardiac tamponade. So it's an accumulation of fluid in the pericardium, between the parietal and visceral pericardium, which you refer to as a pleural effusion. If the pressure from the pleural effusion is enough to compress the heart, especially the right ventricle, because its wall is thinner than the left, you get decreased diastolic filling, decreased stroke volume, and therefore decreased cardiac output. There's several causes, so you get things like vascular causes, so aortic dissection or cardiac wall rupture as well, which is a complication of MI, which is what we were hinting to in this case. You can get infective causes, so pericarditis, especially viral pericarditis, where you get a buildup of serous fluid rather than blood, or TB, tuberculous pericarditis as well. Chest trauma is kind of the obvious one, where you can get bleeding into the pericardial space. Metabolic causes like uremic pericarditis, so kidney failure, you get buildup of uremic toxins and inflammation of the pericardium. Idiopathic, so unknown causes happens occasionally, and iatrogenic causes from cardiac surgery. Malignancies, so mostly any malignancies here have been metastatic to the pericardium, usually from lung or breast. A primary tumour of the heart or pericardium is very rare. And then endocrine causes, so in hypothyroidism, you get myxedema, heart disease, where you can get fluid accumulation. Okay. So recognizing this, you get tachycardia, hypotension, and these muffled or distant heart sounds, they're usually referred to as distended neck veins. So you're getting essentially venous congestion, fever if it's an infective cause, and then obviously you're looking for things like if they've got difficulty breathing, any chest pain, difficulty swallowing potentially as well. So the build-up of fluid around the heart can actually also put pressure on the esophagus, which is behind, essentially directly behind the heart as well. And we refer to this main triad of symptoms in tamponade of low blood pressure, muffled heart sounds, and distension of the jugular veins as Beck's triad. And those are kind of the main three signs that we look out for cardiac tamponade. So the treatment for tamponade involves draining the fluid from the pericardium. So very small effusions that aren't causing tamponade are usually treated with NSAIDs or colchicine. But when you've got cardiac tamponade and you need to relieve that pressure, the preferred method is surgical drainage in theatre, pericardiotomy, so you incise the pericardium open. So it's preferred when it's blood that's in the pericardium. If there's any trauma, purulent effusion, so from an infective cause, or neoplastic disease, and where there's potential for complications or reaccumulation. So if a tamponade is caused by a ventricular rupture or an aortic dissection, the pericardial sac is going to fill faster than you'll be able to drain it by pericardiocentesis. So it needs to be done in surgery, not through needle aspiration. But in other cases, you can do needle aspiration called pericardiocentesis, or in emergency management, so when they're already in cardiac arrest or peri-arrest, preferably under guidance of ultrasound, usually sometimes fluoroscopy if you're in the cath lab. But if no imaging is available, it is possible for someone that's trained to do so to go in blind using just anatomical landmarks only. And then in terms of their treatment, you just need to be very careful about fluid resuscitation, because giving a lot of fluids, although it will help their blood pressure, putting their blood pressure up means that they're going to bleed more into their pericardium. So we actually do something called permissive hypotension, where we allow them to be hypotensive while we're treating the cause of the tamponade, to stop it from being exacerbated by giving too much fluid resuscitation. So that is tamponade. So almost there now. So this is our next case. So we've got a 43-year-old man who's admitted to hospital with pneumonia. After a sputum sample was sent off for microscopy culture, he was put onto IV clarithromycin. He also takes chlorpromazine for schizophrenia. But later that day, he suddenly goes into ventricular fibrillation. Why do we think that's happened in this case? So someone knows their H's and T's already. Can anyone think of a reason specifically for these two medications, why it might have happened? Antibiotics, yeah. It's definitely long something is what I'm getting at. Yeah. Yeah, that's right. Recent chat, long QT, yeah. So clarithromycin and chlorpromazine both cause QT interval prolongation, and that predisposes you to going into VF. So being on both those medications at the same time is what's caused that in this case. Very good. Okay, so toxins, there's so many different drugs and toxins that can lead to cardiac arrest. It would be impossible to cover all of them, but you can broadly group them into how they cause cardiac arrest. So respiratory depression is a common one, so sedative medications and alcohol. Opiates cause central respiratory depression, and nerve agents as well. Circulatory depression, so things like sodium channel blockers, lidocaine, phenytoin, beta blockers, digoxin, amphetamines all cause circulatory depression. You can get CNS depression, so things like antidepressants, benzodiazepines, barbiturates, salicylates like aspirin can all cause CNS depression in high enough doses. And then there's other things like hypoglycemic agents, cyanide, paracetamol, heavy metals, anything that can essentially be a poison can cause cardiac arrest. So there's such a variety of different toxins that there's no one specific test or feature to look out for, but you need to consider what was found with the patient potentially. So kind of in an exam scenario, you'd be told that the patient was found with these blister packs around them or something. You could look for things like needle track marks as well in IV drug users. Think about the patient's medical history. So do they have a drug abuse history, any current medications that they're on, any medications that they could have taken from family and friends at home? What drugs are they prescribed and what have they taken? Was anything that interacts with each other prescribed, and thinking about side effects? Were they taking any herbal supplements or over-the-counter medications that we didn't know about on prescription? And you can send blood and urine samples to toxicology, but depending on what the toxin is, it might not give you much more information. You also want to look for some different symptoms and signs. So things like bradycardia, reduced GCS. You can either have dilated or constricted pupils, seizures, flaccid paralysis, vomiting. And then investigations, you might want to look for an arrhythmia on ECG. So if it's due to digoxin, for example, you get the digoxin effect, which shows up in ECG, or ABG results. So usually a respiratory or metabolic acidosis, depending on what the agent was. And those can all offer clues to what's going on. But it's hard to be certain unless you can directly ask the patient what they've taken. So in terms of treating a toxic cardiac arrest, so you want to think about airway management early, so specifically tracheal intubation of unconscious patients instead of using a bag valve mask to decrease the risk of aspiration. And if they've got respiratory depression from opiates, then you want to think about ventilation for them. Hypertension in toxic causes usually responds quite well to IV fluids and vasopressors, so things like noradrenaline infusion if it's required. try and correct any other abnormalities you come across in your A-to-E assessment, hypoxia, acidosis, electrolyte derangement. You can give activated charcoal, which is very good at reducing GI absorption of many different poisons and helps them to be kind of eliminated from the body without being absorbed. But it only really works up to about 1 hour post-ingestion, and then after that, it's not really of any use. So you'd need to know kind of when they actually took the substance and that it was taken orally for that to be of any benefit. And then definitive management will just depend on the toxin. Many don't have antidotes, but some things do. So opiates have naloxone, for example, and there's a few more on there as well. It's important to remember that sometimes the antidotes can also be causes. So with amphetamines, you give benzodiazepines as a reversal agent, but they are also a cause of toxic cardiac arrest. You need to be careful with how much you're giving. It needs to be done very carefully. And then throughout this, obviously the normal ACLS algorithm is just being followed throughout. So that's toxins, and we have one more left. So here's our last case. This one should be fairly straightforward. So a 62-year-old man is admitted with central crushing chest pain, tachycardia and syncope. As the ED nurse is performing the 12-lead ECG in resus, he goes into cardiac arrest. Why do we think this has happened? Yeah, definitely. So in this case, the last of the H's and T's is thrombus. So this case was an MI, so it's a coronary thrombus, but there are the two types that we talk about in our H's and T's. So we have pulmonary embolism, where there's an obstruction to the pulmonary artery. So that might be venous from a DVT, so thinking about risk factors like surgery, immobilization, long haul travel. Could be a fat embolism from long bone fractures, air embolism from indwelling lines or penetrating trauma, or amniotic fluid embolism. So the amniotic fluid or fetal debris can enter the maternal circulation in things like placental abruption. So that's something important to consider when you're in the maternity unit. And then you can have coronary thrombus as well. So acute coronary syndrome, where there's coronary artery obstruction with STEMI and end-STEMI. So that can be due to atherosclerosis, so plaque rupture. You can get coronary ulceration, fissures or dissections that result in a thrombus, infectious embolism, like infective endocarditis. Rarely you can also get AF thromboembolism as well, so clots in the atrial appendages from AF. They will commonly lead to stroke, but actually they can rarely also lead to coronary obstruction as well. So anyone with risk factors like family history of heart disease, angina, that sort of thing, diabetes, hypertension, if they're a smoker, if they're obese or got high cholesterol, those are all risk factors for thrombus. So in recognizing that, so for pulmonary thrombus, so you want to look for acute shortness of breath, tachypnea, they got any pleuritic chest pain, hemoptysis, tachycardia, hypertension, increased JVP, signs of DVT as well. In someone who's in arrest or going in, or in peri-arrest, going to be at risk of cardiac arrest, then you might see a drop in their end-tidal CO2 on capnography. There's increased dead space in the lungs, so there's no gas exchange for CO2. Okay, and then for coronary thrombus, so the central crushing chest pain with radiation to the left arm or jaw is the typical presentation. But a lot of these are atypical presentations as well. So you can get epigastric pain, back pain, right-sided pain, sharp pain instead of crushing pain. Some people get no pain at all. And then alongside that, there's so shortness of breath, pallor, nausea, tachycardia, syncope, ECG and troponin findings. And essentially anyone who's in VF or VT in cardiac arrest, you want to think about coronary occlusion, because coronary occlusion is the most common cause of those rhythms. So with CPR ongoing, if you're equipped with a cath lab nearby, then you can actually do angiography while CPR is ongoing, and essentially do PCI there and then during resuscitation. So the treatment for thrombosis effectively for both is just restoring blood flow to the affected area. So in pulmonary, it's giving the IV fluids, high flow oxygen, that sort of thing, but you want to get rid of that clot through thrombolysis with autoclaves, or you can do surgical embolectomy if thrombolysis is contraindicated. So if they've had a recent hemorrhage, stroke, recent surgery, or if thrombolysis was unsuccessful. And you can consider ECMO in patients that are in cardiac arrest to support with organ perfusion while the underlying cause is treated. And then coronary, so again, oxygen, start medical therapy with your dual antiplatelet therapy, like aspirin and clopidogrel. Emergency PCI, as I said, can be done with CPR ongoing, or if PCI isn't available or hasn't worked for some reason, then you can do thrombolysis with autoclaves again in that case. And again, considering ECMO to support end organ perfusion. Okay, so that's the main reversible causes of cardiac arrest, your 4Hs and your 4Ts. The very last thing I was going to mention is that there are some other causes as well. So arrhythmias, things like SVT, AF, or different heart blocks, they can progress to a cardiac arrest rhythm. You can get traumatic blows to the chest, so those can lead to cardiac arrest, but without causing hypovolemia or tension pneumothorax or tamponade or any actual structural cardiac damage. It's known as commotio cordis, if you want to look it up, but essentially it's a blow to the chest and they go immediately into cardiac arrest. And that's commonly seen in sporting, like in baseball and things in America. It happens occasionally where someone gets hit at high impact in the center of their chest and they drop to the floor immediately and go into cardiac arrest. And that's called commotio cordis. Other electrolyte abnormalities, so glycemic control, magnesium, calcium as well. Neurological issues, so subarachnoid hemorrhage, intracranial hemorrhages, and strokes and seizures. They've got an electric shock, so exposure to high voltage shock can disrupt the heart's electrical activity. Cardiomyopathy, so it's a genetic condition. The heart's muscle becomes abnormally thick, leading to increased risk of arrhythmias and sudden cardiac arrest. And then congenital defects present from birth. So some individuals are born with structural abnormalities of the heart that will increase their risk of having a cardiac arrest. So that is the end. So if there's any questions, you're more than welcome to pop them in the chat. Our next session is on shock, which will be on the 23rd of March. I'd really appreciate if everyone could fill out the feedback form just by scanning the QR code. It's really quick, just to give us a hint of what you thought of the session and anything we could do in future. And this link here is just some more information. So we've got lots of information on our website online about this in one of our articles. So you can read over that too. Thank you.